Thank you, Dr. Priyankur, for the kind introduction. And Shrutika, that was a wonderful talk. Thank you for enlightening us with all the available protocols for poor responders. Now, what I will be talking on is actually a continuum of what Dr. Shrutika just said. I'll be elaborating on one of the strategies used for poor responder patients, that is dual stimulation. So as we all know that the poor responders in IVF has been a baffling riddle, and it puts the clinicians as well as the patients in a very challenging and a frustrating situation. Despite the number of protocols or despite the number of products which have been launched to help these patients, the response, none has been actually proven to improve the reproductive outcome. That is what we were just discussing right now. But the prevalence of these patients is pretty high. And in spite of trying everything, the live birth rate still remains very low, and it is less than 10%. Now, what has been observed is that the best outcome, the best marker for outcome is the number of eggs. And in one study, it was actually found that even the increase in the number of egg by one, it drastically improves the success rate. So all our efforts are actually aimed at improving the oocyte yield, to improve the number of eggs we can collect from a patient so that we can increase the live birth rate. Dual stimulation is actually one of the strategies to, in that step only. It helps us increase the oocyte yield in a minimum number of, in the shortest period of time, especially in patients which have got poor ovarian reserve or patients with advanced age where we are rushing against time. So it's particularly suited for patients, as I said, with advanced age or low AMH. It has also been used in patients when there were no oocytes or no competent embryos after the conventional follicular phase stimulation. And also, it has also been utilized in patients undergoing fertility preservation for cancer treatment, wherein, again, we are rushing against time and we want to preserve as many oocytes as possible. Now, before we actually discuss the protocol for dual stimulation, let us just have a brief review of the physiology of follicular recruitment. Though it is not fully yet clear, but since ages we all believed in a single cohort, single wave recruitment of follicles, and which has been the basis of our follicular phase stimulations. But in the recent times, we have got more knowledge about this, and there have been other theories proposed, like the continuous recruitment theory, wherein it is said that the follicles grow and regress continuously, and dominant follicle is randomly chosen. And also, there have been a suggestion that it can be a multiple cohort of follicles which are recruited, and then dominant follicle originates from the major wave. Now, this better understanding of the follicular recruitment, plus the excellent vitrification techniques we have these days, have formed the basis of these random protocols or dual stimulation protocols, which have helped these poor responder patients. Now, what exactly is done in dual stimulation? Now, as the name suggests, it's double stimulation in the same cycle. So there is a follicular phase stimulation, which is followed by a luteal phase stimulation. Now, most clinicians prefer doing a estradiol priming in the previous cycle, which is for better synchronization and coordination of the follicular growth. The follicular phase stimulation can be any of the protocols which Ritika just described. It could be a mild stimulation protocol, or it could be a conventional protocol using 225 to 450 units of HMG. Most researchers and most clinicians, they actually use a flexible antagonist protocol to prevent the premature LH surge. However, some people have also used progestins and or ibuprofen to prevent the LH surge. The analogs are usually used as a trigger, but some people have actually used recombinant HCG and urinary HCG also. And then the oocyte retrieval is scheduled as per the protocol 34 to 35 hours after the trigger, and whatever embryos are formed, they are then frozen. After the follicular phase stimulation, the luteal phase stimulation starts. Different people have done it after 2 to 5 days of follicular, after doing the oocyte retrieval. And then it can be the same protocol as the follicular phase stimulation, or it can be some change in the protocol. Progestins are usually added in the luteal phase, not only to prevent the premature LH surge, but also to prevent the menses, especially if the luteal phase stimulation protocol lasts a little longer, because though you don't want to do a oocyte retrieval while the patient is having periods to avoid the chances of infection. Again, whatever embryos are formed are again frozen. Now, the pilot study in this evaluating the role of dual stimulation in poor responders was done by Kuang et al. And the protocol became famous as what we know as the Shanghai protocol. So all the patients who were expected to have a poor response, depending on the age or the antral follicle count or the FSH levels, were included in the study. Now, they used a little complex protocol because they used a combination of oral ovilogens. Actually, both clomiphene and letrozole was given. The clomiphene was started from day 3, and which was continued till the day of the trigger. And letrozole was started from day 3, but given only for 4 days. HMG was added every alternate day from day 6 onwards, and it continued till the follicles, the dominant follicles were reached. GnRH analogs, triptorelline was used for the trigger, and they also gave ibuprofen to prevent the LH surge on the day they gave the GnRH trigger and also on the next day. The oocyte retrieval was done, and all the follicles which were more than 10 millimeter were left, while they were not dominant, between 10 to 12 were left for the luteal phase stimulation. They started luteal phase only if they could see 2 follicles more than 10 millimeter, between 8 to 10 millimeter after the oocyte retrieval. For the luteal phase stimulation, they started HMG 225 units every day, and again the analog was used for trigger, and then the retrieval schedule. All the embryos definitely have to be frozen. You cannot do a transfer in the same cycle. Now, what were the results were? The total number of M2 oocytes obtained were higher after the luteal phase stimulation. However, the fertilization rate, the cleavage rate, and the mean number of viable embryos were similar after both phases of stimulation. The study included 38 women, and they found that of these 38 women, 68% had at least 1 to 6 viable embryos after the dual stimulation, compared to only 48% after the follicular phase stimulation. Of these 26 women, 21 women underwent embryo transfers, and of them, 13 women ended up having clinical pregnancies. There was no difference when they compared the embryos in the luteal phase and the follicular phase. There was no difference in the embryo survival rate, the clinical pregnancy rate, the ongoing pregnancy rate, or the miscarriage rate between the embryos, whether they were obtained from the follicular phase or from the luteal phase stimulation. So these authors concluded that it provides opportunities for retrieving more oocytes in a shorter period of time, avoids cycle cancellation, and increases the possibility of pregnancy. And the embryos derived from both these stimulations, they have the similar developmental potential, so it could be a new hope for the patients with poor ovarian response. Subsequent to this, Vareli et al. Conducted a study wherein, in addition to the dual stimulation and freezing of embryos, they also did a PGTA for all the embryos. And the protocol used was almost similar, just that they used recombinant FSH and recombinant LH for stimulation, and a flexible antagonist protocol was used. And luteal phase stimulation was done irrespective of the number of enteral follicles seen after the first oocyte retrieval. All the embryos were cultured till day 5, and all the blastocysts thus obtained underwent trophectoderm biopsy. The results were as follows. They found that the duration of stimulation and total dose of gonadotropins used was higher in luteal phase stimulation. However, a significantly higher number of M2 oocytes were obtained. The fertilization rate, the mean blastocyst rate, and the euploidy rate was similar between the embryos obtained from luteal phase and the follicular phase stimulation. The total number of euploid blasts were more after luteal phase stimulation. 90% of these poor responder women had at least one blast, and of these, 65% had at least one euploid blast at the end of the duostim. And there was no significant differences between the clinical pregnancy rates, the miscarriage rates, or the ongoing pregnancy rates when the embryos from both the stimulations were compared. Now, after this, there was like a lot of studies done, a lot of research done on the dual stimulation. So this is just the summary of the various studies. Most studies, the protocols used are more or less the same, except for some minor changes that one group of researchers used chorepolytropin alpha followed by recombinant FSH. So initial 6 days, they gave only 1 dose of chorepolytropin alpha, which was followed by recombinant FSH. Most of the studies yielded similar results, that the number of M2 oocytes obtained were higher in luteal phase stimulation. And otherwise, the embryos, the blastocyst rate or the euploidy rate was similar between the luteal phase and the follicular phase stimulation. However, one recent study done last year, they found that a significantly less number of oocytes after luteal phase stimulation. Now, this could be because they used a mixed population. Some patients had, of the total number of patients they included, 53 patients had poor ovarian reserve, whereas 24 patients were actually undergoing fertility preservation. So it could be a mixed population which they studied, which resulted in the results not in flow with the other studies. Another finding which was observed by Liu et al. Was, though most of the researchers did not find any difference between the trigger used, but these group of researchers found that if the analogs or recombinant HCG was used for trigger, the number of embryos were higher compared to when urinary HCG was used. Now, this has been quite surprise why we get more oocytes in luteal phase stimulation and not in follicular phase, where conventionally we've just been doing stimulation in the follicular phase. It could be because of a more synchronous follicular development because of high estrogen or progesterone. It could be because of increased angiogenic factors after the initial oocyte retrieval that promotes the sensitivity to FSH. Could be a flare-up effect of the GnRH agonist, which is used as a trigger for the initial stimulation. Could be because a higher gonadotropin is consumed and it is the increased duration of stimulation. But these are just the speculations and they still need to be proven before we can start using dual, before we have more clarity on what is the basis of getting more oocytes in luteal phase. This is my personal experience at my clinic. This is an ongoing study which I am doing. This is just an interim result I thought I'll include to share my personal experience. So far, I have done dual stimulation for 36 patients with poor reserve. My findings are in line with what the other literature has been showing, though I find the duration of stimulation is definitely a day or two longer in the luteal phase compared to the follicular phase. Dose of gonadotropins definitely goes high because the duration is also longer. The antagonist use is almost similar. The number of oocytes, the M2 oocytes, I found slightly higher in the luteal phase compared to the follicular phase. The fertilization rate and the mean blastocyst rates are still comparable. But this is still in the interim. I have not actually got the whole results. So maybe next time I can share the full results once my study is complete. Now, this is another group of patients, group of researchers who did this dual stimulation for patients undergoing fertility preservation. And they also concluded that it is the best way to get maximum number of oocytes in the minimum time period in this group of patients. Now, one important concern has always been, because conventionally it has been a follicular phase stimulation, whether the embryos derived from luteal phase stimulation are strong enough, what is the perinatal or the obstetric outcome of the embryos derived from this. So this was a study done by Chen et al. And they studied the embryos derived after luteal phase stimulation and compared it with the other, those derived from follicular phase. And they found that the babies which were born after luteal phase stimulation embryos, there was no significant difference in the gestational age, birth weight, length, or the congenital effects, or the incidence of neonatal deaths. However, this was a retrospective study, and it lacked proper control, so more studies are needed to evaluate the perinatal and obstetric outcomes. So in the line of the available evidence, continuing with that, if we do a SWOT analysis for dual stimulation, I feel dual stimulation definitely gives us a higher number of oocytes and embryos are obtained in per cycle. More patients have euploid blasts for transfer, and there is no difference in the competence of the oocytes obtained either from luteal phase or follicular phase stimulation. It reduces the time to obtain one competent embryo. It is better tolerated sometimes than 2 consecutive follicular phase cycles, but this is, however, theoretical. The weaknesses are that a higher number of cancellations have been seen in luteal phase. There is no RCT doing a cost-effective analysis comparing a luteal phase, a dual stimulation, or 2 follicular phase stimulation. A freeze-all approach is mandatory, so you need to have a good vitrification program in your clinic. And so far, it has only been applied to poor prognosis patients. As I said, the cost effectiveness is still not there, and there's an increased dose of gonadotropins which is needed. And then the studies about the obstetric and perinatal outcomes are pretty limited, so we need more studies to evaluate that as well. So to conclude, it is favorable, definitely favorable for patients who would need more than one stimulation, and higher number of oocytes, M2 oocytes, blastocysts, and cryopreserved available embryos are available. The cycle cancellation rates are pretty less. It minimizes the time of accumulation of oocytes. Although the initial obstetric and neonatal outcomes are comparable, we still need further large studies. More studies are needed to confirm the safety of luteal phase stimulation in terms of ovarian and follicular microenvironment. And because a mandatory freeze-all protocol is needed, and there is a lack of cost effectiveness, these are the weaknesses of dual stimulation. The recent ESHRE ovarian stimulation guideline for IVF ICSI, however, stated that though the number of eggs obtained after luteal phase are more, and the dual stimulation may seem to help patients with poor ovarian response, in the absence of RCT comparing a dual stimulation with 2 consecutive follicular stimulation, they do not recommend the current use of dual stimulation for poor responders. The recent Delphi consensus, however, stated that it should be used only when the urgency to obtain oocytes is there, including patients with advanced maternal age and poor reserve, or in patients undergoing oocyte cryopreservation for malignancy. Thank you.
Thank you, Dr. Manisha, for that wonderful talk. And the best part was you sharing your own experience in your clinic, which makes it all the more foolproof, I must say. Dr. Manisha, I just wanted to ask you one thing. Can we, like estradiol priming is of course beneficial in these patients for synchronization. If a patient lands up all of a sudden on day 2 and you plan to do a dual stimulation, so is it possible for us to do it in case if we do not have time for the estradiol?
Yes, of course. See, in fact, I said what was actually what I went through all the papers. But in my personal experience, I've actually done without a estradiol priming also. And I've got, see, honestly speaking, I'll say I'll have got mixed kind of results. There's a lot of counseling also needed. It's not only the results. Patient needs a lot of counseling when you have to tell them that you have to undergo a dual stimulation. See, in an Indian scenario, it's not, it's like you, because the success rates are so low with any kind of protocol we've been using, it's very difficult to counsel patients to take injections for all 30 days in a month and tell them maybe after that also we are not sure of what is happening. So that is the reason why, in spite of me trying to conduct this study for almost 1.5, 2 years now, I've been able to enroll only 32 patients. But saying that, answering your question, there have been incidences wherein patients have just come to me on day 2 and have counseled them about a dual stimulation and they're ready to go for it. So I have done it and the results have been comparable.
Sure. Thank you, Dr. Manisha. And of course, both yours and Shrutika's talk were based on counseling, I guess, and poor ovarian responders, we all know counseling is the most important part.
Yeah.
Thank you so much once more.
Thank you.